test to make sure I can actually change slides still. Okay, there we are. Sweet, so we're all set. I think you may just kind of have to let me know when to switch over, or
Sure.
next slide or something like
Yep.
that. But yeah, then we should be pretty much set to go. Give me just a sec to get that up on the other computer for the actual speakers in the room. I'm not sure if they'll really need much of a reference, but yeah, I'll be right back, and I think we'll be starting this time.
Sounds great. Thank you.
Yep.
All right, well, good morning, everyone. And to kick it off this morning, this is going to be our workshop on Sustainable Prescription Monitoring Program funding, CMS certification. So I think something a lot of us are maybe going to look into in our states. I know we are in South Dakota, so I'm anxious to hear this presentation. We have 2 speakers in person, and 2 will be remoting in. So here in person, and Pam, I should have asked you how you said your last name. Okay, Pam Zamitis is here, and she's a senior consultant with Health Tech Solutions. And Cameron McNamee is here, and he is the Director of Policy and Communications at the Ohio Board of Pharmacy. And then doing their presentations remotely will be Jennifer Marlowe. She's the Prescription Monitoring Program and IT Project Coordinator at the Maine Department of Health and Human Services. And then we'll have Carrie Majors, the Vice President, Executive Director of Sync Health Nebraska, Sync Health Iowa. So their presentation is all together, so I think Pam is going to go ahead and kick it off.
Listening to all the other great presenters and having time to think about it and everything, but it reinforced, I think, the importance of everything that you guys do. I'm sure they get caught up in the day-to-day things and lose sight of that sometimes, but what you do is extremely important, and we're all grateful for that. It gave me the chance to talk to some people too, and hear more about what all you're doing, which is great. You guys have a lot of good things you're working on, but additionally, you have some challenges. I mean, do not have a lot of staff. You have a lot of things you need to do. And one of the things is funding. And I know that can be a challenge. So today, that's what our presentation is on, hoping that we can share some knowledge that will help you out in the future and move on from there. But as we said, we have 4 speakers today. So just to give you a little bit more background about myself. So I'm with Health Tech Solutions. Our company is based in Kentucky, but I'm actually in Pennsylvania. I've had the opportunity to work with Nebraska and Maine and several other states on PDMP certification, but additionally, I've worked with other states on MES certification as well. So some of the state systems like enrollment and eligibility and everything. I used to work for the state in Pennsylvania, the Medicaid program. I oversaw the Promoting Interoperability program there for 8 years. So I'm fortunate to have some of the Medicaid background and everything, which is important with this. I also am part of the Medicaid Enterprise team. We're a team, we work with CMS on the Promoting Interoperability program. So I've had the opportunity to work with CMS directly as they implemented and introduced the certification. So hoping that some of the information that I can share will benefit all of you. We're going to test this. We haven't tested this before we started, but I'm going to introduce now, or have Carrie introduce herself. She is virtual, so go ahead, Carrie. If you can hear me, can you introduce yourself?
Absolutely. Can you hear me, Pam?
We can, thank you.
Very good. Thanks everybody for having me. Carrie Majors, Executive Director of Sync Health. We are the Nebraska and Iowa Health Information Exchange and the Nebraska Prescription Drug Monitoring Program, for those who are not familiar.
Great, thank you. Let's keep going virtually. Jen, do you want to introduce yourself?
Yeah, I wasn't prepared for that, but sure. Jennifer Marlowe, I'm the Prescription Monitoring Program and IT Project Coordinator for the state of Maine, the Maine Office of Behavioral Health. Our PMP is located right in behavioral health. Thank you.
Thank you. And Cameron.
Hi, I'm Cameron McNamee. I'm the Director of Policy and Communications for the State Board of Pharmacy, and thanks for having me.
And you don't need a microphone.
No.
Okay, so I'm kicking off today's presentation. I have to say, with 4 presenters, you would think that we would split this time evenly, but no, they have given me 45 minutes, so you're stuck with me for 45 minutes. And hopefully I will be able to share a lot of knowledge to help you out. You're going to hear some similar information as we go through. I'm going to try and give high-level information, and then the other speakers are going to give more detailed information of their experiences as they've gone through certification. Just, to let you know, I'm sure you're all very well aware, every state's a little different. Your process is different. Where your PDMP resides is different. So this is all going to be, the process could be potentially different for you than it was for those that you're going to hear from. So keep that in mind. Also, CMS did release this guidance in 2022. It is something that could change. So what we're presenting now could be different next year. So we're presenting what is currently the requirements and everything. So just wanted to share that. Also, on behalf of myself, and I think I can speak for the other presenters, we do have the contact information at the end. Very happy to answer any questions that you might have, either today or later. And I wore orange, so it was easy for you to find me if you had any questions afterwards. So want to kick it off. Some of this I'm sure you are completely aware of. So a lot of the current funding is for grants and general funds, or comes from that, either CDC, SAMHSA, the BJA, or CMS. That's something that I'm sure I do not have to share or explain that to you. What I did want to cover is a couple other options, one of them being the Support Act funding, and then high-tech funding. And as you will see, the dates, these did end, but wanted to go over some of these just to explain. I think it'll help give you a background of why these potentially could have been important or helped. So the Support Act funding, it was provided by CMS, but through the state Medicaid programs. So that specifically, so that was, oops, went ahead. That became law in October of 24th, 2018. That provided funding for PDMPs to become qualified PDMPs, and also included some reporting requirements. It was 100% funding. The challenge with that, it was that because it wasn't made into law until October of 2018, the funding ended in 2020. So as we go through this and you hear like the process of requesting funding and everything, it can be a long process. So the timing to have to request that and get approval and then have to use it by the end of 2020, it was a challenge. So there was not a lot of states that were able to take advantage of that. But I did put together a map, just wanted to share the states that did receive that Support Act funding, and give you an idea. Didn't go through the amounts or anything, but did want to share that with you. The other funding that wanted to talk about was high-tech funding. You may or may not have been or familiar with that. This was introduced with the ERA high-tech rule in 2009. And this is actually was introduced, that's the program I worked with at the state, the Promoting Interoperability Program. And the purpose of that was to provide incentive money to physicians and hospitals in order to provide incentives for them to implement electronic health records. In order for them to receive the incentive, they had specific requirements they had to meet. And one of those was the option to query PDMP. So because of that, there were some of the states received funding in order to help for integration, to help integrate more providers and practices to the PDMP. And so just wanted to share the states that got that. Again, that funding ended September of 21, so that's no longer available. But the reason I wanted to bring these up, the consistencies with these is that both Support Act and high-tech funding came through CMS through the Medicaid program. Because they both came through the Medicaid program, it created that relationship that was likely not there before. You know, I know I've talked to some of the Medicaid programs have no idea who or even where their PDMP sits. So I think those that were able to get some of those funding, they did, they have been able to build that relationship. It also provided, I think, to both, you know, I have here a Medicaid program, but I think even reinforced to CMS too, the benefit of the PDMP to the Medicaid program. And that's important too, especially with the funding that we're going over today. That's clearly something that CMS will ask. And so any of the states that have had the opportunity to go through these, I think it made it even more clear to the state Medicaid program, the benefit that the PDMP can provide. It also created the funding mechanism because a lot of the PDMPs do not reside in Medicaid. It provided that mechanism to transfer funds from the Medicaid program to the PDMP. So, you know, I think all of this being said, CMS does understand the importance of the PDMPs, but did want to share too, your state did not have to receive either one of these in order to receive the funding that we are going to talk about today. So what we're talking about today is what we say is MES funding. You'll hear MES, you'll hear SMC. So MES stands for Medicaid Enterprise System. So you might have also heard of MMIS. That's what the Medicaid program always used to refer to their systems. So like eligibility, enrollment, claims processing, those. CMS realized that there's more than just the state-specific systems that benefit Medicaid, one being PDMP. So they had expanded and they now reference, instead of using MMIS, they will use MES. So you might hear those interchangeably, but really Medicaid Enterprise System it broadens the scope a little bit and includes systems like yours. Because of that, your state does, or your PDMP does have the opportunity to request funding through MES, through your state Medicaid program. This is being funded by Medicaid, the program, CMS. Then, well, it is being covered by the Medicaid program, but one of the things I want to make clear and kind of highlight a couple times is the fourth bullet. Because the funding is being provided by Medicaid, CMS will only cover the costs directly benefit the Medicaid program. So I want to say that again. If you figure with all of your PDMPs, you have more than just Medicaid providers that access, you have more than just Medicaid beneficiaries, in that CMS, because it's their funding, they want to make sure that they're funding what they believe is the percentage that's the benefit to Medicaid. And so we will go over that in more detail. I know I have slides on that, and I know the other presenters do as well. Let's see. And so then lastly, on here, we have that in order to receive this funding, the states have to go through what is called streamlined modular certification. So that's going to be a big part of the topic today. So why would you want to do MES funding as opposed to grants and everything? One, there's no end dates. We'll go into more details about this, but this is something that does need to be requested every year, but it can be continuous. So once you get certified and you have this funding stream available, there's no date that it's absolutely going to end. Once you're certified, the whole process is a lot easier. Each year you still have to submit funding request, but you can update that. If you want to add items, you have the option to add items later. But getting that in the process in place, getting that funding in place makes it a lot easier later on. And then once you're certified, CMS will provide what they call, you'll hear, enhanced federal funding. CMS will provide 75% of the funding that benefits Medicaid, and then the state would cover the 25%. So I'm going to go over some of these. I know the other speakers are going to talk about this too. For those of you, I come from the Medicaid program, so try not to use all the acronyms and everything and trying to explain this high level. The state Medicaid programs, they request their funding through what they call APD, or Advanced Planning Document. They can request it for planning. So if they're just in the process of planning what they want to do, they can request funding for that. They can request funding while they're in the process of implementing it. Or you might hear of that referred to as DDI, or Design, Development, Implementation. And then they can request funding for operations. They also have general funds. So some of their costs that don't fit into any of those buckets fall into general funds. So as you can see, the amount that you can receive varies depending on what you're requesting. So in planning, and then also in the implementation stage, or the DDI stage, you can actually get 90-10. So they will cover 90% of the funding, and then you would cover 10% of the funding. Once you're in operations and you get certified, then they'll cover 75 and 25, and then that's continuous. They may come back. They did release some regulation earlier this year that did say they have the opportunity to come back, or they have the option, they might come back and they could ask for updated documentation on something, just to verify that the system is still continuing to operate as it requested. And then one thing to keep in mind, as we discussed, is the cost allocation to determine the Medicaid benefit. And then just one thing I'm going to highlight real quickly, depending on when you want to request funding, you do have the opportunity, because all of you guys your PDMPs have been in operations. So you're going to fit into the operations standpoint at 75-25. If you do decide to implement something new, you do have the option to add that at 90-10, something you could work with your state office about and everything. But for the most part, you would start out at the 75-25 and then work from there. If you can go back and say that you started working with the state Medicaid program a year ago on something and really were putting funds into that and everything, you can request funding back to 2 year, retro funding back to 2 years when you put in the funding request and work with your state about that. So streamlined modular certification, that's the new funding, that's what they call it. This is what CMS introduced last year. They have introduced it not only for systems like PDMPs, but also for all of their Medicaid systems. There's a lot of states that have systems that have been operating for years that aren't certified, and they are now being asked to go back and meet the certification. Anything they're bringing in new, they have to do it for all of that. So this whole process and streamlined modular certification is not new to the Medicaid program. What might be new is their understanding of how it works for PDMP. It's a little different. They may not be as familiar with the cost allocation part. They don't usually have to do that. Their state systems are Medicaid only, so they don't have to do certification or cost allocation. But just so to give you an idea, this is what you're going to reference or hear about the streamlined modular certification. And again, just to highlight, to get the 7525, you would have to go through the SMC process and obtain certification. Did put a link down there. I know the presentation is available online. CMS has a page with all kinds of information about this. So if you want to take a look at it later, I wanted to make sure you had access to that. So a couple of the items to highlight as part of streamlined modular certification. Oops. Oh, sorry. Let's get here. I'll start. Okay. Okay, so CMS, they have a site they call GitHub, and on that they have like what they consider like their key modules, their key business areas. They have all of their MES modules on there, you'll see, but they do include PDMP on there. When you click on the link for PDMP, when you look at that, they have 6 what they call outcomes. And associated with each of those 6 outcomes are metrics. So basically, in their mind, if they're going to certify something, they believe that the PDMP system needs to be meeting those 6 outcomes at a minimum. They want to make sure that the system's operating like they expect it to be, and that's where they go with the outcomes. You'll see all of their systems have the CMS required outcomes. Associated with the outcomes are what they call metrics. The metric's going to be some kind of either data or evidence or something that supports the outcome. So that's going to say, okay, you can provide this information, and that's going to show, look, our system is meeting this outcome by meeting those metrics. Additionally, they understand, or they realize too, that okay, they have these 6 required outcomes. They're all regulation outcomes and everything, but they understand that states also have goals that are different, or in addition to what CMS might have. So they ask that the state provide at least one specific outcome. So something that your state is interested in, something that's a goal, or maybe it's related to opioid crisis or something you want to track. They will ask you to provide at least one outcome and metric related to that. Let's see. Sorry, I think I clicked on something here. Sorry about that. I keep hitting things with my paper, and now I'm getting a message. I'm not able to advance it here. Maybe there. Oh, there. Okay. The other thing that they have, I apologize for that, they have an operational workbook. The operational workbook's going to include all the metrics. That's something that they ask for, something that they want the states to include. So something that needs to be provided. A couple of the key elements, just highlight these real quick. The OAPD is the funding request. They also have what they call an intake form. In the intake form, there's 22 conditions for enhanced funding that they need to be completed. They're all regulation. They all need to provide evidence. And then they have evidence and documentation needed to support certification. So just real quick, I know I want to pass it over to some of the other presenters, but CMS has what they call the operational readiness review. Their normal process is a state would have that they're interested in a system. They decide they want the system, they do the preparations, they find a vendor, and they start through the implementation. Before they go live, they're supposed to go through an operational readiness review if they want to receive enhanced funding. This is going to walk through, they're going to show the system, show that it's meeting the requirements, and then CMS will kind of give the stamp of approval, you can go live. Then 6 months after that, all those metrics that we talked about, they want those in the operational workbook. They want 6 months of that. They will look at the metrics. They will look for any inconsistencies. They will ask about that. And then they will go through the certification review. At that point, then once certification review is completed, they give the approval, then the system is certified and you receive the enhanced funding. Because the PDMP is already in operations and just now asking for funding, what CMS will do, they'll do what they consider a combined ORRCR. So there'll be a big day event that leads up to it. They'll walk through a lot of the process and evidence for that, and then you'll go through that combined. Okay, so just to reach out and highlight cost allocation. So CMS, again, will only pay their fair share. They do not have a standard cost allocation. This is something the states need to provide. They need to work with their state officer, their state, and get it approved. It has varied across the states. It's very important you work with your state officer. We have come up with a wide range of options for that, but that is something that does need to be done. It can be based on the Medicaid program. It could be potentially provider-based or patient-based. Lately, they've been wanting things that are more transaction-based, what they've been asking for. So then but the cost allocation percentage is important on what you're gonna actually get funded. And so I know the table I have next, I have a table with an example just to show you, and I'll highlight it, I think. Can you move to the next slide, please? There, I apologize those in the back if you can't see this, but just wanted to highlight a couple things here. And I know we started late, but I want to make sure I give our presenters enough time. So I'm going to try and go through this quickly. Just use an example here. So if you have funding that request of $2 million, and then the next column you see is cost allocation. Use 3 different examples just to get an idea. This is something that's confusing and hard to explain to a lot of people, even the Medicaid program, if they're not used to doing this. So use 20, 40, and 60% just to give you an idea. So let's go with the 60%. So the cost is $2 million. If you get cost allocation at 60%, the column that I have circled shows 800,000. So that 800,000 is the amount that CMS will not fund. So that's the amount they're not going to fund. The amount after that in the next column is the amount that they will fund. It's at $1.2 million. So then you think, okay, now they're willing to say, okay, we believe that 60% of what you do benefits Medicaid. We're going to give you a cost allocation at 60%. We'll cover the $1.2 million. But then it goes to operations. So then of that 1.2, they'll give you 75% of that. So they'll give you 900,000. And then the state needs to cover that remaining 300,000. So reason I highlighted both of those 2 columns, one, the first column, that's funding that CMS is not going to touch. You can cover that funding however you want to. You can cover that with grants. You can cover that with whatever funding's available to you. The 25% state match, because CMS is covering 75, and that's federal funds, the 25% match cannot be grant or cannot be federal funds. So that does have to be state funds. It does have to be from a general account or something like that, or a way that does not directly come down from federal funds. So wanted to just highlight that, just to give, I know that has been at times a challenge for some of the states to come up with that 25% match. Again, it's the second column that's highlighted, not the first column. So here, just real quick, you guys have these slides you can go through, that it just kind of gives you just high level of the certification process, what's included and everything. Also hit some of the key milestones. Just highlight some of the things that are important. I think initially is getting, if you haven't had the opportunity to reach out to your Medicaid program, that's one of the first steps. Get them involved, get their approval, make sure they're okay with all of this. Okay, so that went through that quickly. Going to highlight some more things. I'm going to conclude the presentation. I am now going to turn it over to Carrie. She's going to walk through what Nebraska has done for certification. Go ahead, Carrie.
Great, thanks, Pam. Can we just make sure everybody can hear me okay?
We can, thank you.
Awesome. All right, perfect. Thanks again, everybody, for having me. It's exciting to come and talk about this, looking back a year later, a little over a year later. We went through our certification review event in August of 2022, and you can go ahead and go to the next slide, please. And now we are reflecting and responding to our first year of CMS reviews on our metrics, and going through kind of those processes that are now new as well, right? And reflecting and seeing how CMS is using the information and asking questions about the information. So I can talk a little bit more about that later, but the slide here is really just about demonstrating our PDMP certification timeline. As I mentioned before, we are the prescription drug monitoring program in Nebraska, as well as the statewide health information exchange. And we do have an integrated system with those two modules. So as we, leaned into the Support Act funding and really worked hard with some of our consultants. We used various consultants over the course of the last few years to assist with some of the work development, the APDs, sustainability planning, a lot of other planning efforts in coming together with other states. Planning for Support Act projects, understanding what the outcome we wanted from that in being able to be a qualified PDMP, and then starting to plan for what did it look like when high tech came to an end, and really leaning into that sustainability of the PDMP, understanding where our blended and braided funding had come from in the past, and where we wanted to make some shifts over to the Medicaid enterprise system and leverage the opportunity to certify these modules, which modules we wanted to certify, what that looked like from an integrated standpoint, and then begin socializing it with CMS, the CMS staff. So I know this looks like a really long time, right? 4 years seems really long, but we really did start talking about that, making sure that we were, in lockstep with our Medicaid program. We've had great partners with our DHHS, Nebraska DHHS Medicaid staff and administrations, which have, transitioned over the course of this timeline as well. And so, there's a lot of relationship development that goes on here. And I would just be very encouraging to you, if you don't have that relationship, to establish it and lean into your amazing network of consultants across the PDMPs in the states, and others that have been through this to, help you, because there is a lot of expertise out there in this realm, and we sure benefited from it. And I would hope that that you would lean into those subject matter experts in this realm as well. I will say that you'll see here that we, scheduled our certification event and then rescheduled our certification event. So we had been doing our 6 months of data collection and had our event scheduled for May of 2022. And a month prior to our certification event is when the streamlined modular certification guidance dropped. And we made the decision, in conjunction with CMS, through a lot of conversation, to delay the certification event and go forward very rapidly with changing some of our processes, our data architecture, and our metrics and outcomes to align with the SMC, so that we could just move forward and be in alignment and compliance with the SMC guidance, and just put that behind us. It just didn't seem right with that dropping to go ahead with the certification event 30 days later and not be in compliance with that. So I will say that was a very rapid transition between, April, when that came out, and our certification event, our joint ORR and CR that took place in August of 2022. But you can do it, and it went fine. It worked well, and I'll take you through some of those steps and some of the lessons learned that we had throughout that certification, that ORCR journey. And I hope that you'll ask questions at the end of the presentation for anything that you would like more clarity on. Next slide, please. We broke this down into a few key phases of certification just for ease of reviewing kind of what our process looked like. The phase one, and I'll focus on this in some upcoming slides here on cost allocation, because I know that's one of the biggest pieces that I get asked probably over the last 18 months to 2 years is about cost allocation. So even though our planning phase really through our certification event was, you know, in discussion and planning for about 4 years, the actual work, I would say the intense work and the pulling together all of the pieces to prepare for the ORCR was about 18 months. And that is in, you know, a pretty intense work group that we pulled together with lots of different people across our organization, across Medicaid and DHHS in Nebraska. And I would say we met, you know, no less than a couple of times a month in the beginning, and then at least a few times a week for the last probably 6 to 8 months as we prepared to, you know, pull all of the information together and be well prepared for the certification review. So that's what I'll focus on in the upcoming slides. Really, in phase one is a little bit more about cost allocation, and then kind of break down like what the heavy focus was from CMS and MITRE in the what I would call the ORR phase of that, and reviewing the evidence, and was very heavily focused on the, you know, certificate or the security and evidence around security, 508 compliance, looking at our metrics, looking at our logic, that sort of thing. And then really the next phase was, you know, providing them all of your evidence and artifacts to review ahead of time, which is, you know, really, I think an important step that saves, you know, if you can get all of that done and out of the way and, you know, streamline that with CMS and MITRE, it does really help for the CR to go much smoother, and also makes everybody confident in the answers and the descriptions that you provide in the intake form as well, and that they're well aligned with what the evidence is that the CMS and MITRE team are looking at. And then just a few like tips and things that we did to make for a smooth demo. I think a few points to cover that are questions that we definitely were asked during the demo, and we did a little bit of pre-work even with our state officer and a couple of individuals, a couple of the subject matter experts at MITRE to help them understand and then, you know, ask advice about how they would want it presented during the demonstration phase as well on the actual day of the CR. Next slide, please. So I think everybody's aware of the qualified PDMP elements, and I would just say we threw these up here so, you know, they were just clear, but you know, they really influenced and helped us be prepared for what those outcomes were going to be, what the PDMP outcomes were going to be in the required metrics and outcomes. And we spent a lot of time with our Support Act funding, leaning into these elements of the Support Act and what is required to be a qualified PDMP. And we, you know, designed a lot of projects to be successful in moving forward with certification and being able to display that we could meet all of these elements and could be you know, measured as such within the metrics design. And so I would just encourage you to familiarize yourself, if you're not, with the elements in the qualified PDMP, walk through those with your Medicaid agency and staff, and you know, ask a lot of questions about you know, the rosters that you're going to use to help them, you know, gain access. They are a payer, and you know, that created you know, a lot of conversation within our organization, being an integrated system and having Medicaid, you know, be a payer and would need to only be allowed to see, you know, their beneficiaries. Lots of conversation that went along with that. You know, what the expectation was and a benchmark, right, for what the benchmark of speed would be for providers to be able to have access, real-time access to the PDMP and, you know, what that benchmark of speed should be. I think there were a lot of detailed conversations that came out of that that aren't necessarily inherently obvious within when you read this, but they do come out during your certification review event. Anytime you're developing a metric on something or you're presenting a percentage, of course, CMS and MITRE want to know what you're measuring it against. So lots of rich conversation that are kind of between the lines of what it is to be a qualified PDMP. Next slide, please. So in reviewing the PDMP outcomes, my history is really working with a lot of federal funding and grant programs. And I traditionally build backwards, right, from an evaluation standpoint. And I think that would be my advice when you're looking at the PDMP outcomes, right, is whether you were a state that had Support Act funding or, high-tech funding or transitioned any of your Support Act projects, into high-tech and now are transitioning them into outcomes-based certification and operations. I would just encourage you to think about, like, look at these outcomes and, build backwards, right? Build backwards what your evidence is going to be. Like, what evidence are you going to collect that demonstrates that providers have near real-time access? Does your PDMP system demonstrate each one of these? How are you going to provide that in evidence? What's that going to look like in the demonstration that you give during the certification review? In designing your metrics, making sure that you're covering each one of these points, and that you have your data sources lined out as to what makes most sense, what shows the most value. For example, the workflow integration, PDMP2, thinking through, how you're going to report on that. Are you going to report, that a health system singularly has access, or the breakdown of the health system into all of the individual facilities within that health system, and designing your metrics that way. We spent a lot of time discussing these metrics. Again, we were a little ahead of the SMC guidance when we were looking at building our metric logic, and then made some adjustments when the guidance came out, and some of the 5042 FAQ and guidance around the logic was being shared around the various PDMPs in the spring of 22. But those are all of the conversations that I would encourage you to have that are in regards to these outcomes, is just looking at it, as this is what the expected outcome is, and build backwards into all of your elements that will go into your ORR and CR. As well as, I guess I'll mention one more thing as well. You can go ahead and advance to the next slide. I would also encourage you to think about your intake, the intake form, the 22 conditions for enhanced funding that you'll have to write a description of. You'll write out what the description is that you're meeting these outcomes, what the evidence is going to look like that you produce. So I think just thinking critically about those from just kind of the different pillars of metrics, evidence, and what you will provide in the demonstration, and start building that and layering that as you go is really helpful to make sure that everything stays aligned, because there are just a lot of working parts to keep aligned as you go through this. Next slide, please. So I said I'd focus a little bit more on breaking down the cost allocation portion of phase 1. The cost allocation negotiations and conversations that we went through took about, I would say, somewhere in the range of 6 to 8 months. There was a lot of discussion. There was a lot of data that was run. We ran data that was transactional based, that was beneficiary based. We looked at, what had been used under high tech and, provider-based cost allocation. Our initial provider-based cost allocation was not accepted singularly by CMS. We went back and looked at the weighting that we could do if we had, provider-based at the core, and then weighted it based on various different methodologies layered on that, what it looked like. And in the end, we were able to have enough data that showed our actual project hours attributed that were direct Medicaid benefit versus all project hours in our organization. This required us to be very transparent with CMS and Medicaid in opening up, every aspect of our organization essentially. And I know this is a little different because we are an external organization as the gateway and host of the PDMP, where, some of you, it's within your, state government agency or your board of pharmacy. But for us, being an external organization, there's a lot of transparency, in the public-private partnership that's required when you get to this level to be able to open your books, open up, all of your, data sources and say, like, where can we, think creatively and think about, exactly what this looks like if the system is Medicaid only, and what it looks like as it's applied to everyone else. And ultimately, we were able to do a weighted approach based on our level of effort that could be exclusively attributed back to Medicaid benefit. And that is where we've landed, and we've been able to remain with that cost allocation methodology to date in our operational and implementation APDs. The only other thing I guess I would say about that is we probably could have communicated even more with CMS on our state team than we did. I think looking back, we would have brought CMS in a lot earlier to the conversations. We had a lot of internal conversations between our working team, our analytics team, and our Medicaid program. And I think looking back, I would have probably brought CMS in a lot sooner than we did, and attempted to avoid the RAI altogether. But hindsight's always 20/20, right? So I think that would be my word of advice and takeaway for all of you, is to bring them in early into that cost allocation discussion. Next slide, please. Process-wise, we already talked about quite a bit of this, and Pam covered a lot of this. I think, having a strong relationship and partnership between your PDMP agency and state Medicaid staff. You're going to need your PDMP vendor involved. There's a lot of security artifacts that are required to be produced as well. So making sure that you understand, what their all of their certifications and are collecting those, and that they are closing any gaps as well throughout the process. Just knowing ahead of time that that's going to be part of the remediation expected if there are any gaps identified or remediation efforts needed within their security assessments and certifications. So I think bringing your PDMP vendor in early and having them understand the process, as well as the expectation with what needs to be delivered for the artifacts and the remediation effort, is really important. The 6 months of data. So reporting, making sure that you're collecting and you have a plan to collect the 6 months of data, and that's also presented at your state DOR board. So that was one of the rushed items that we had to get in front of our state DOR board. And then we used the minutes that showed that the state DOR board had seen the metrics and had plans to, continually review and utilize the data coming from the required PDMP metrics. And that was part of what we provided for artifacts. And that portion was definitely rushed on our end. And I think we, looking back, we would have done more advanced planning, knowing that our state DOR board only meets a handful of times a year. And, trying to fit that puzzle piece in ahead of the certification event was not well planned out on our end, and I would do that differently. Making sure to pay better attention to when the DUR board meets. Next slide, please. So this just kind of lists out the steps that we went through with the certification event. So, you know, our CMS project officer, working closely with them in the MITRE group, being able to clearly demonstrate with the benefit to Medicaid, to the providers and beneficiaries, going through system architecture and the technology platform. So we provided a lot of system architecture diagrams ahead of time. Our integration diagrams, since we were integrated with our health information exchange as well. Being able to clearly demonstrate and identify the PDMP functionality that is required as part of being a qualified PDMP. Going through all of those privacy and security tests, security artifact documents. And I will tell you that went very smooth during our demonstration, our actual CR event and the demonstration, because they had looked at everything ahead of time. We had answered any questions. We had gone back and, you know, cleared up any questions they had, or any, collected any remediation efforts with timelines that the vendors were needing to complete as part of their certifications. And then preparing the platform demonstration. So we did make sure that we had screenshots of everything that we wanted to demonstrate in case technology failed that day. We weren't able to do them live on the system, that we had backup. Being able to demonstrate clearly each one of the metrics, show that we had 6 months worth of data, the consistency, answer any questions for anything, any trends that had changed during those 6 months, was definitely heavily focused on during the certification review event. Next slide, please. We already talked a little bit about this, who should be involved, making sure that the individuals that you have during your certification review event can speak intelligibly and confidently on the topic or question. So we did a lot of rehearsals. I think we did about 4 or 5 where, you know, the last 2 we did full walkthroughs. And I will tell you, those are very, very beneficial. They might seem silly at the time when you're planning. I'm like, oh, I already know what I'm going to say, or, you know, I know how this is going to go. But once you get into it, and especially all of you that know me, can be pretty long-winded at times. And those certification review events you have to go pretty quickly in order to fit all of the information in within the time allowed. It's usually about like a 6 or 7 hour you know, Zoom call. And so we worked out a lot of kinks as we did the walkthroughs, and that really helped the day flow a lot smoother. So while it may seem like a silly step, it really was beneficial to go through, and we are really glad that we did that. And then had screenshots, and you know, were really able to produce the documents if they wanted to relook at something or revisit a piece of evidence or an artifact. To be able to have that kind of shared, we use Box, have that shared folder handy and be able to pull that up and go, you know, directly to that piece of evidence, or look at the calculation and the logic, things like that. So being prepared with all of, you know, the various technologies and folders and things is really important as well. Okay, next slide. We talked about this a lot. I think in phase 2, the one thing I will hone in on is, again, those security documents, and the few things that we did get questioned on a lot were the 508 compliance, 508 compliance testing. I know we had a lot of back and forth with CMS and MITRE on that the vendor must test, and then if they fail a defined threshold, they have to create an action and resolution plan. The full compliance is not mandatory. It wasn't at the time when we certified, but they had to have basically a roadmap for when they would meet that, you know, when they would be, the vendors would be implementing those enhancements to meet 508 compliance. So I think we underestimated what would be asked there, and there were a lot more questions about 508 compliance than we were expecting. And so a lot of time was spent on that. And then with the pen tests and disaster recovery plans, I think it's important to make sure your vendor understands that funding is tied to the documents and they're not optional. They have to be provided to CMS and MITRE to review. And that there is flexibility in how the vendors can transmit those documents to CMS and MITRE. We went through this with some of our vendors and making sure that those documents stayed secure and protected, and that they knew exactly who was looking at them and how they were going to be stored, so that they could safeguard any of that data that they didn't feel comfortable, having, just having out on a, shared box folder or something. So there is a lot of flexibility in that. Next slide, please. Again, to keep the demo running smoothly, I think, conduct those dry runs. Make sure you're not recording the portions of the demo that have the live and sensitive data. That is a requirement during your certification review event, which is to show production data. So we did spend time because we did integrated, we certified our health information exchange, PDMP and event notification modules at the same time. We did look across the Medicaid beneficiaries with our Medicaid staff and, selected a test patient that was, had adequate data, and we could look at the consistency and talk about the use cases for, the value proposition, the benefit back to Medicaid, and, kind of demonstrated that way the value that Medicaid gets from these systems, and as well as, being able to show that live patient data. Our Medicaid agency did handle all of the consent that they felt was necessary to be able to show that that live patient data during the demo. But I think making sure you don't record those portions of the demo, that you shut that off, and have screenshots to show that functionality. But, are redacting any of that information before, you're exchanging PowerPoints, that sort of thing, is an important reminder there. Next slide, please. Again, I talked about this a little bit about privacy and security, and, just being prepared, to, be able to talk about those, have a place in your presentation and slideshow for those, but not necessarily displaying any of that information in your PowerPoint and during the demo as well. And then, thinking through both the DUR board report and documenting that as a requirement for, how you're using the PDMP metric data, and then preparing for that DUR annual survey for metric 5.1. Making sure you're considering those and aligning to those as best you can. I think in how we transmit data to Medicaid and CMS monthly, post, how we documented it and then continue to submit it post certification is very much aligned to that DUR annual survey, and being able to, look at the trends as well. We do it in Excel and are transitioning that to a dashboard. So happy to talk more about that one-on-one if anybody has any questions about how we continue to report. Next slide, please. Post demo, I think just making sure that you have bandwidth to remediate any issues that come back in the tear out from the CR, and have working sessions set up with your state team and then CMS and MITRE to discuss any clarifications or questions based on the tear out. And then the certification letter comes about 2 to 4 months afterwards. I think Pam, you can correct me if I'm wrong, but I think we had ours like in December, so it was about 3 months from the time of our certification until we got our letter. And then we were able to go back and do the request for retrospective funding back to the beginning of the federal fiscal year. Next slide. Pam's already put these up, but just again, citing the resources for the Streamlined Modular Certification guidance, and then the annual DUR survey, in case you have not seen that and need that reference. So I think that concludes my portion of the presentation. Pam, I'm not sure who I'm handing over to. I think Cameron. Looks like Cameron. I'm happy to take
All
any
right.
questions at the end of the presentation.
Great. Well, thanks everybody. Again, my name is Cameron McNamee. I'm the Director of Policy and Communications for the Board of Pharmacy. I'm going to talk to you about Ohio's experience with PDMP certification. We did not use any consultants. It was really done in-house, although you should hire Pam because she's excellent. But I'm here to show you that you can do it too if you're scrappy enough. And so, ready, next slide? Yeah. Great. So here's some disclaimers. Again, we were the first state to do certification, so things may have changed. In fact, I think we were certified before the draft guidance was even out, or the draft guidance was out, the final guidance was not out. And then in terms of required documentation processes, procedures, work closely with your CMS product officer. I'm going to highlight that and emphasize that over and over again throughout my presentation. And all of our certification materials, if you want them, are available to you. So you can take our materials and go with them. So you don't have to necessarily start from scratch. We have very liberal public records laws in Ohio. So all of our materials are available for you if you want them. So you don't have to sort of feel like you're starting from ground zero. We already talked about MMIS and MES. Again, 75% for operation of systems, and so that's what we're talking about, that funding source. Yeah. So for key stakeholders, your state PDMP agency, so that's our Board of Pharmacy, our state Medicaid agency, includes people from data, IT, and legal. IT and legal are important, again, for any kind of data agreements that need to be done. Advanced planning document submission team. So our CMS, or our Medicaid agency has their own team that is responsible for APD submission. So they were brought on board. The folks that are responsible for system certification in-house, as well as the pharmacy and medical teams at your Medicaid agency. We were fortunate enough to get high-tech funding, and so we already had these existing contacts. So we were, the conversation was, okay, high-tech is ending, where do we go to next? And that's how we landed on system certification. One other thing that I've talked to a few states about are, you will have to have laws that require data sharing between your Board of Pharmacy and Medicaid. You're going to be able to need to do your allocations. You're going to be able to need to do metrics. And so we were very fortunate a few years back working with our legislature to just have a very broad data sharing provision in our statute to allow for that with our Medicaid agency. And then on the next slide, state IT. So we have something called Innovate Ohio, which is a platform that is really focused on the state's data governance. And so they're really helpful. Our CMS product officer, so they're assigned to one or more states, and they're the person that you bounce ideas off from the jump. So we didn't wait to engage CMS. We actually just started, we would get Jamie on the phone and we would say, here's what we're thinking about our metrics. What do you think? And he was like, oh, that sounds great. And here's what we're thinking about, these are the ones we have questions on. And then he would work with us to get those clarifications. So again, engage CMS early days. Bamboo Health, or at the time I think it was Apparis, but then was moving to Bamboo. And then MITRE. You might have heard about MITRE. They're sort of a group of external experts that advise the government. These are the people that are going to be asking a lot of questions that you may not think are relevant to in your CMS certification. So they're going to be asking about like, oh, well, how does this system work? And how does that system work? And part of it is a little bit of their curiosity. So like, we'll tell them, okay, like Natalie was on the call from Bamboo and she was like, all right, well, you just need to sign an NDA. And they're like, yeah, we're good. So, it's a little bit of they like to kick the tires a little bit, but, don't get too freaked out if they start asking a lot of random questions. So again, we talked about funding and certification as a two-part process: advanced planning document submission, which is annually, and system certification, which is that one-time process, or system certification / operations review, which is a one-time process. They're separate. Again, they're interrelated. APD, this is where we put all of our cost allocation methodology in it. It's done every year. It's usually started, like, we submitted it at the end of July, but we normally start discussing it in March. And so really, you need to work with your Medicaid on their timeline. So again, the PD&P section is a very small part of that larger document, basically asking for all this money for all these systems. And so you really want to not hold up that process, because they've got to get this through, they've got to get their approvals through, they've got this process, and so you want to be respectful of that. So for the PD&P, it requires at least 4 items: the cost allocation plan and methodology, the total cost for system operations for the year, including staff, contractors, and contracts, table of organization for staff covered under the proposal, and then the contract language itself. Next slide. Yep. So for existing systems, again, it covers 75%. So then you need to really prove how the system benefits the Medicaid population. So during high tech, they were very generous. Yeah, they were almost like, okay, we'll pay for the whole thing, but just don't tell anybody, because they had the money and it was there. So they were very generous. They are not as generous with this round of funding. So you need to really have some hard and fast numbers that really you can tie back to the Medicaid population. Again, work with your project officer, because they'll be able to sort of run whatever you're thinking of up the chain and come back and say, yep, that's good, and you can kind of keep on moving with all the other things you have to compile. So we did it based on prescriptions in the system. So if they were a Medicaid beneficiary and they received a prescription, that basically was the allocation methodology compared to the total number of prescriptions in our prescription drug monitoring program. It's going to, again, if you're not a Medicaid expansion state, it may be trickier for a higher cost allocation. I'm not sure, but probably. And so we are a Medicaid expansion state. But again, we're looking at about 36% so we're getting about 75% of that 36% that covers the total cost of the system. So again, it is, I consider it sort of a piece of the pie. It's not going to fund your entire operation, but it will sort of relieve a lot of pressure on, like, if you're doing statewide integration, they will cover statewide integration to, about 2%. So it does sort of help provide that at least sustainable regular funding that then you can build your other funding sources off of. Again, total costs for annual system operation. You need to include a breakdown of all staff and operating costs. So we included the Bamboo contract, which includes PD&P hosting, NARCS care, gateway, and then our staff. Only include staff that are 100% working on your PD&P. I think it gets very complex and confusing if you start half splitting staff. So if you want to put staff on this, my recommendation is, if they're 100% funded, or if they're 100% working on the PD&P, so that's their job, they live, breathe, and die the PD&P, then they can be funded. But if they're doing some other things, that's where it gets a little tricky in terms of covering staff. So here's our timeline. We did it in about a year. So we met with our Medicaid, because again, the high tech was rolling off. And so we were kind of like, well, we got to pay for this somehow. And so we were up against kind of a funding crunch timeline. And so our Medicaid agency was very receptive and understandable about how we're literally asking for a rounding error from their perspective, but it's like the world to us. And so that's kind of another thing that, to explain to them how important it is. But again, we met in 2020, and from in October 2020, we started the initial meetings. November 2020 to July 2021, we had regular, I think, once every 2 weeks we'd meet and do status updates. And luckily, again, we have an APD team at Medicaid, and so they're all project managers. They're like, okay, guys, like, here's the readout from last time. Here's what we got to get done. So they were very, very helpful. We sent our draft certification. So we compiled all of our metrics from November 2020 to July 2021. We submitted our draft certification materials to CMS and MITRE for initial review. Again, it's important, you need to have all those materials packaged and ready to go. And then the certification meeting was about 5 hours and included MITRE, CMS, Department of Medicaid, Bamboo was on there as well. And they have 60 days from the review to issue determination regarding certification. And we got that certification approved by CMS on the 28th of October. And again, it is retroactive back to the start of the fiscal year. So in terms of the materials, we started with a PowerPoint because we were the first state to do it. We just assumed that they had no foundational knowledge of how a PDMP operates. And when talking with our project officer, it was kind of clear that he sort of knew, but wasn't like 100% sure what PDMPs can do. So really, if you want to start from a very baseline of here's what it does, here are the basics, because I think there are going to be a lot of people on that call, and they may not all be experts, and they're coming from MITRE and other places. So they may be IT experts, but they may not understand how PDMPs work. So really, having that PowerPoint with sort of this baseline foundational knowledge is really important. And again, certification is a process where you educate CMS on PDMPs, but then you also need to learn a great deal about how Medicaid and CMS operate. So it is sort of a bi-directional learning experience. We provided them as a zip file. Actually, this is old, but again, we can provide you that same zip file if you guys want it. And then we worked off that intake form, which we covered previously. So this is sort of what the intake form looks like. Again, it's required outcomes and metrics and conditions for enhanced funding and state-specific outcomes. So there's little tabs at the bottom, and they have sort of the different items in here. The way we did it was, again, we went through in the spreadsheet, we said, okay, here is what the here's what the required outcome is, and here is our evidence. And then we included like an evidence folder where they could go and access that evidence. So for example, the time elapsed between, so we said providers can easily can access PDMP information through workflow integration, which may include electronic prescribing system or controlled substances. So we included, average time to request patient, as well as we had our a local health system that is integrated do a video presentation in a test environment to show how integration works. And that worked. Conditions for enhanced funding are not as straightforward as required outcomes. They're actually kind of terrifying when you look at them. So that's why I encourage you all to just take our materials, because it took a little while to figure out what exactly they were asking for. So they're really highly technical in some situations. And really, you want to work with your project officer to even see if they are even applicable, because some of them don't even apply. How we did it in Ohio was we just created a document that literally just went through all the conditions of enhanced funding and responded to every single one of them if we could. So for example, next slide, you see here, the CMS determines the system is likely to produce a more efficient, economical, and effective administration of the state plan. So we talk about how all prescribers in Ohio are required to check the PDMP, and most pharmacists are through our rules as well. We added studies showing the effectiveness of the PDMP in Ohio, and then we included reports from like the GAO showing how integration is beneficial to providers, saves them time, allows them for more interaction with their patients. So that's just sort of one example, but you really have to sort of build up, that evidence to show them that you can meet these requirements. This is another one where you just, first of all, for E&E systems, again, that's eligibility and enrollment, right? So not applicable. So really you're sitting here wondering what Magi-based system functionality is. You don't have to worry about it. You can keep on pumping there. You just say not applicable and keep it moving. Post-certification metrics. So we do ours annually. Nebraska did their certification a little bit differently, but we do ours annually. And essentially, it's just the Support Act metrics with some additional items added. Again, as part of our post-certification metrics, so we did agree to begin matching our data set on an Innovate Ohio platform. So Innovate Ohio allows basically us to put our data, Medicaid to put their data, and then it matches, and then each agency can pull down, and we can lock it based on, you know, who has access rights. And so they were really excited about being able to match that data and have that data accessible and usable for Medicaid. And so that was a draw for them. And so that was a thing we agreed to. We were, again, it's a bit of a process getting all of that loaded onto the system and matched. So we're still working through that, but they understand. Also, our Medicaid did a bid for new managed care organizations and a new single PBM. So there were some things like with the DUR that they gave us a year to do because they knew we were still bidding our single, or we're still getting our single DUR and all the new managed care organization on. So they were very understanding and gave us some flexibility in terms of meeting certain timelines. Again, these are the post-certification metrics. As you can see, a lot of these you've already had to prove in the initial certification, so you're just kind of re-upping. Again, the one thing that is Medicaid, that is very Medicaid dependent is 6, PDMP 6, which requires them with their PBMs and their pharmacy department to do sort of work with the DUR and get some metrics out of the Medicaid. Fortunately, they've been able to do that without any issues, so. And that's it for me. I'll turn it over to Jennifer.
Well, hello, everybody. We're actually going to do kind of a little bit of a change in plan right now. Carrie has to leave in about 15 minutes, and we want to make sure that you guys have a chance to ask questions for Nebraska, so just for Nebraska, if you have any at this time. That way, you know, you can get some of those questions answered before you leave today. If there's no questions, Carrie's still available. There are her emails at the end of the presentation. But if anybody has any questions that they want to ask, please do so now.
So Jen, just so you can hear, I don't see anybody have any questions specific to Carrie. We will open it up at the end again too for more, but at this point, if we get any, we'll let you know, but I don't see
Sounds
any.
good.
Anybody have any questions for Carrie from Nebraska before Jen does her part? Okay, go ahead, Jen.
Okay. So how's everyone doing? That's a lot of information. It's been about an hour and a half of you guys kind of just sitting there. So I'm not sure if everybody just wants to do a really quick, quiet, stand up, 30-second stretch just to kind of move your body because you've been sitting there for a little bit. I'm not going to do a countdown like Jeopardy. I'm not as good as that. But we can, you know, quietly count to 30 and do a quick get up, stretch, move your body, and then sit back down before I go. I only have 4 slides, so that's a bonus for you guys. Pam, let me know when they're all stretched out.
They're all doing jumping jacks, Jen.
All right. Somebody counting at least?
No, you can, I think you can go ahead. They're standing, but they can listen.
All right. I can't see you, but Pam's going to be my eyes for me. How many of you have completed a streamlined modular certification funding review? Raise your hand if you have.
Cameron didn't raise his hand, but he did. That was it, Jen.
All right, just Cameron, got you. So everyone here is either in the process or they've received a review meeting for a streamlined modular certification funding review with CMS. So right now, Maine is working towards getting their review meeting. We've put in for or we're putting in for an IAPD / OAPD. So our funding system or our PMP system has been working since 2016. We've had Bamboo, or 2018, we've had Bamboo since then. And we're just looking to implement 2 of our enhancement modules, or 2 of our modules for enhancement. One of them is the Section 5042, which is going to help with that DUR reporting, that kind of mechanism, so that we don't have to go in and pull it out. We don't have to go in and get all that information. Bamboo is going to do it for us. And then we wanted to do a really great enhancement to the organizational management module. if you don't know what that is, it's a module for CMOs, supervising supervising staff for prescribers. And what they can do is they can go into the module, select their prescribers, of course, making sure that the prescribers consent to it, and they can review their prescribing habits within that module. Unfortunately, what happens is if you're a provider that's or a CMO that's in a hospital and you have 1,000 or 500 prescribers, that's quite a cumbersome process, right? So what we wanted to do is kind of streamline that process and provide a dashboard that allows them to have that kind of one-stop look at those prescribing habits for their prescribers and see any prescribers that might be practicing risky prescribing behaviors. So that's why we're looking for, one, the operational, because we've already had our system in effect since 2018, and an implementation to those enhancements for 5042 and the organizational management. You guys will all notice that throughout the presentation and the slides, we have these great little, you'll see some boxes here, and some of the other slides, we have those circles. We wanted to provide slides that just aren't a guide to kind of help you in this process, but a guide that kind of helps you for a checklist, right? You see that here, we all decided, of course, we're all going to say the same things because these are beneficial and important attributes when trying to do your certification. Here you'll see the check boxes on who we feel are necessary. You'll see some circles on points that we really want you to hone in on. And then those little, bullet points of tips that you'll see throughout the presentation. So key players for Maine right now are, of course, me, because I'm the most important here in Maine. Just kidding. But the PMP coordinator administrator. The reason that they're important is because, one, they kind of manage that system, right? They know the data, they know what the system can do and how it can function. So you want to include those into your meeting. You want to include your data analyst. Why? Because they can analyze and manipulate data the way that maybe you can't do. I know I can't do it, so it makes sense. But you want to have them in there, and they know that data and the ways that they can maneuver them to get what you're looking for. So I'm going to come back to the program financial officer in a second. The Medicaid partner, without them, you wouldn't be able to apply for this funding. That's one. And two, your Medicaid partner helps you identify areas, and we'll go into it further in later slides, help you identify areas that maybe you didn't know you needed to look at, such as risky prescribing behaviors or fraudulent payments, things of that nature. Of course, your vendor, or some states have a data collection repository. Your vendor is important is because they're going to help you identify areas such as your cost allocation. They're going to help you maneuver through the process and the meeting and help you kind of guide with your security items and those extra areas where maybe you just don't know how that system plays and works. Of course, CMS MITRE and Cameron went into an amazing explanation on why they were important. And then health tech solutions or a project coordinator. Maine doesn't endorse any vendor, but Jen does, and she endorses Pam because Pam's amazing. That's why she's here today. She's really helped guide us to what we need to do, what metrics we really need to focus on, the security documents that we need to have in play, questions we should be asking. There's a whole slew of things that are just escaping my mind right now, but those are just some of them. So I talked about the program financial officer. And the reason I talked about this is here in Maine, I had a supervisor and she had some health concerns, which took her out of work for several months. Before that, she was really kind of a player in this. She was part of a key player in this. And I kept hearing from her that don't worry about the funding, it's all set. Don't worry, don't worry. Well, little me, I didn't worry and I got a little naive about it. And come down to, we had to have a meeting about, hey, where's this money going to come from? Where are we going to get our 10% or the PMP's portion of the funding? So I sat down with our program financial officer and we went through all of the, we're looking for this enhancement. I want this. It's a ride or die enhancement, that kind of thing. And she said, okay, Jen, I agree with what you're saying. We've come to agreement. Now, where's the money going to come from? And I said, funny, Adrian, that's hilarious. And she goes, no, seriously, where's the money going to come from? Are we going to have to do an emergency legislative session for a budget review? Are we going to have to pull funding from general funds and then do something? Where is this going to come from? It wasn't without efforts from the program financial officer and then several other people in the office here that we were able to find a sustainable source to kind of fund the system, since our vendor was kind of, our contract was done and we were starting a new one. OD2A, which was our primary source of funding the PMP, was no longer in place since they went from OD2A, regular OD2A to OD2AS. So this is why I'm saying the program financial officer is really an important aspect of this as well. You need to know where that funding is coming from. If you're like me, where your PFO is up here and you're kind of down here, you really need to make sure that all of these people know what's happening at every time. Get ahead of the game. You know now that it's going to take 6 months to a year, so start contacting these people. Even if your supervisor says it's all okay, get that in writing. Make sure that they've included the PFO just so that they're aware of it as well. Next slide, please. So this is main cost allocation. Right now, we kind of, serve for the two primary groups, right? Dispensers, which are the pharmacies. You can see we have general pharmacies, and then we have our Medicaid pharmacies, which account for 280. Together, that's 316, which is going to give us about an 88.6% cost allocation. Again, we're still in the process of getting a review meeting. We've asked to see if this cost allocation is approved, and we're hoping to have, if it's not, kind of a backup plan that we can kind of run towards. It's a high cost allocation. Just going to point that out. It's a high percentage. We're not sure if it's going to go through, but we're fingers crossed. So everybody in the room, cross your fingers for us. Next slide, please. So I guess the biggest question is, hey, we're doing all this stuff to get Medicaid funding through CMS. What's the benefit for Medicaid, right? So we talked about prescriber monitoring. By us implementing that organizational management, it allows those CMOs, it allows those even prescribers to view their own prescribing records. They already have that now, right? Maine has currently kind of implemented a high-risk prescribing referral process. So this allows this to kind of, for CMOs to see that occur ahead of time. It allows us to do some prescriber monitoring, right? Making sure that prescribers are in fact, billing for the correct information, they're on the correct patient, all of that information is correct, which kind of ensures accurate and kind of mitigates that overprescribing need, right? Patient monitoring, this allows CMS and PMP, or Medicaid and PMP, to work together to monitor those patients to make sure that there's one, no doctor shopping, two, that they're not getting a medication that they've just paid for through Medicaid and then turned around and did a private payment for another prescription, or another, saying that they haven't received it and getting another prescription. And that kind of goes into fraud payments, right? Making sure that prescribers aren't overbilling, patients aren't duplicating billing prescriptions, those kind of things. And the other one is clinical closures. And how does that benefit Medicaid? So we had a closure here last year in Maine, and I'm sure you guys have all heard of it. What happened was the practice closed and 400 patients were without care. We were able to work with Medicaid to develop a process that we weren't allowed to contact patients, but Medicaid were. And because we have that data sharing agreement in our legislation that allows for that to occur, they were able to contact those patients and identify them, reach out to them to make sure that they had some kind of care or a prescription in place in the meantime until they were able to find a prescriber to help them. Next slide. So these are Jen's rules of fun, at least for now, right? Carrie's given you hers, Cameron's given you his. These are Jen's, right? Like I said, contact your Medicaid office now. You might need some data from them. You might need them to give you some beneficiary information for prescribers and patients. You need to get that flowing now, because they need to reach out to their vendor to make sure that this is all applicable, and it might take time. So reach out to them now. How far back are you asking? Are you asking for retro funding that's going to happen in April? It needs to, one, be included in your OAPD, IAPD And it needs to be on your metrics. You need to make sure. So we were going to go back for April 2022. We needed to include those on our metric sheet and have that information available for them and the reason why we're asking for retro funding. Like I said, justification needs to be added. Here's the other thing. How are the funds paid, right? So if you're asking for retro funds, like I said, our system was paid through OD2A. We're going to have to pay that back if we ask for that retro funding. Is that something that's worth it for you? Don't forget the total number of metrics and the type of metrics. Make sure that your system can handle that metric that you're requesting for. You don't want to have a too complex metric that you won't be able to account for, or that's so complex that you won't be able to identify it easily. Biggest thing I can say is the longer you wait to get your OAPD in, the farther the date for review. We had a conversation with MITRE where you had that initial conversation to ask your questions that you're wondering about, your cost allocation. Do we need to include any specific metrics? They told us that they were already, that was in August, I believe. Pam, correct me if I'm wrong. They told us that they weren't even getting meetings in until November to December, which means you have your meeting, they review it, and if everything looks okay, you get your funding, or you get your funding in 2 to 4 months from there. So the longer you wait to get that APD in or OAPD in, the farther the date for review. Again, I only had 4 slides because everybody is so amazing and they talked great about everything that you didn't need to hear much from me. So I'm going to turn it back over to Pam for highlights and recommendations.
Great, thanks so much, Jen. Thank you, Carrie, too. I know you need to drop soon.
Yeah, no problem.
Thank you all.
Hey, Pam, I'll just contribute to that last statement that Jennifer made, as far as the timeliness of a submission of your OAPD, and then the cost allocation, approval that comes along with that. We were a full 7 months from submission until we had approval of the OAPD with the cost allocation methodology. That was a 7-month time frame. And then certification review wasn't for an additional 6 months. So that retrospective application of the funding, rolling it back and getting that 25% essentially back, because we'd been operating under 50-50 basically for the entire federal 22. And then they, retrospectively applied that 25% back. So, I mean, that was a full year, of funding impact. By us not sending that OAPD in until the beginning of the federal year. So definitely, planning ahead that 6 to 8 months is absolutely necessary. Like if you don't, if you're wanting to reduce the budget impact, and the coverage of that. So just add on to that, Jennifer, that was our experience as well.
Yeah, I'm going to feed off that really quick. One of the other things that really needs to be a concern in your mind is how are you going to pay for this system while you're still, working through this? Your OD2A is going to run out. How are you going to pay for it in the meantime so that your vendor is not working at risk? So.
Great, thank you. Good information. So our plan was we were going to stop at 9:30 and give you guys a half an hour to ask questions. We are past that. I still have 10 slides. I'm not going to go over those. Want to open it up for questions, but one thing that I just want to add and preface this by saying I'm not speaking on behalf of CMS. I did not get disapproved by CMS. My experience, and even if you had listening to these 3 states talk, and I know there's states out there working on this process now, it has not been consistent. It's very different. Carrie was talking about the OAPD and their delay. 3 of the states we're working with now were told they needed to submit the OAPD first, get it approved before they would consider certification. Another state, not. They're moving forward, and after they get certified, then they're submitting the OAPD. It's different. I know a lot of them too, or I think all of them recommend it, and highly recommend too, getting your state officer involved. I know, as Cameron had mentioned, so each state has a state officer. Each state officer has 1 to 3 states, depending on the state officer, and then they're in regions. Most of those state officers have to go up to their regional lead for a lot of the questions and everything. But talking to some of you here, some of the things your state officers are saying, It's not what other state officers are saying. I know they are trying to make this more consistent, but it helps to have these conversations, to find out, okay, well, other states have been able to do this. We've been told we can't do this, or we have to do it this way. Unfortunately, it makes it hard to even say, here's exactly what's going to happen, because it's not necessarily going to happen the exact same way. Additionally, we have found from the Medicaid side, we have some that are so hands-on and they are involved with everything. We have another one who says, just call CMS yourself and set it up. Very responsive, very helpful. They are there when you need them. They are not ingrained into everything you do like some of the other ones. The other thing to keep in mind too is bringing in CMS is very important. The MITRE team, CMS contracted MITRE. They're a contractor for them, and all they work on is certification. As they mentioned during this, they will be the ones reviewing the documents. They will be the ones asking the questions. They're going to want to make sure that Medicaid agrees that PDMP is important in your state. And you have, you're going to have Sharon Yeske, who is the PDMP person from MITRE. She will be on all the calls. You will have someone that's security focused. That's something that's going to be consistent. But we have seen that in a little difference from the state too, where the Medicaid likes to keep tight rein of that connection with CMS and MITRE. And they may or may not involve you as much as you want to be involved. So, kind of push your way in there. I think it's very important for you to hear. I think I was trying to jot down some notes that the rest of the folks were saying. One of the things in addition, and I think this was in relation to some of the state perspectives, but we have seen from a MITRE perspective in those meetings, they have said one thing, and I know Carrie alluded to this because we ran into this. They said one thing 1 month, 3 months later, they said something different. You can go back, make note of that, write that down and let them know this. This is what you told us, this is the route we went. Now you're saying this. Make sure you have that in writing, and they have gone back. I have seen them go back to what they originally said, and make sure your key people are involved. I know, and Carrie's still on. Carrie, I know you can attest to this. We had an issue where Sharon was not involved at the very beginning, and some of the things we were told was not from her perspective of being the pharmacy lead from MITRE. So then came in late to the game and started changing some things that we had been working on for months. I've seen that in other states and things too. So just wanted to say some of that just to keep that in mind. But all in all, I mean, it's a teamwork. It's a good, I know it sounds like a ton of new things that you haven't heard. It sounds like a ton of work. But again, once you get that in place and you have that, our goal is, I know a lot of you are, Bamboo states, they have been extremely proactive and very helpful with working with the states, pulling all the documentation that Carrie said it needs. Like they're working on that, goal is, go through a couple of certifications with some state and hope that streamlines the whole process for other states to get into the process better and smoother. So kind of real quick summary, we have 15 minutes, want to open it up, see if anybody has any questions. If you have any for anybody specifically, any just general questions, any thoughts, anything at all you would like to share. We'd love to get your thoughts and feedback. Jeffrey, do you have a question, or were you just raising your hand? No, oh, I'm sorry, I didn't realize she was coming.
I didn't. Thanks, Melissa. Hello? Yep. Okay. Maybe more for Carrie or Cameron, since you two are the only ones who've gone through it, I guess. I'm curious, the maintenance of the certification, what's required after you get that approval? And then secondly, how are you getting your funding back to you? So what are you submitting to CMS to get that percentage back, and how often are you doing that?
Yeah, so the APD is an annual requirement where you have to recertify that percentage. So we have to crunch those numbers every year to determine what the percentage breakdown is for the cost allocations. So that is an annual thing. I did actually get an update from Chad. So when we first started this, we actually had to report our metrics annually. They are now making us report monthly, right, Chad? Yes. Yeah. So again, there will be matching involved. At least from our perspective, the way we've done it. Again, moving to that IOP and having it already pre-matched, I think will assist with that process. But yeah, so that's some of the things that have changed since we started this.
Carrie, I'm sure you want to weigh in on that one. I know you have some insight.
Yeah. we had set up to report monthly from the very beginning, and have been doing that now for over a year. With the annual report that has now come out from CMS that we are just working on right now. It's due in November, and it is not as aligned to our monthly, like basically our metric scorecard that we've been reporting on monthly. It's not as aligned as we were hoping it would be. So we are working through those challenges right now in looking at, what they're asking for in the annual report versus how we set it up monthly. And, we'll align to that going forward now, having seen it for the first time. So I would encourage everybody to have those conversations early as well about what reporting is going to look like, what the expectation is going to be, and then talk about like the format that you're going to report, because I think that's been something we thought we did really well. And now seeing that even on the backside now of what the annual roll-up looks like, there is some misalignment that we'll have to go back and, fill in gaps on. So, we thought we were very proactive reporting monthly, knowing, and then hearing that there was only going to be an annual report. But that misalignment is a challenge for us right now that we're working through.
So have you gotten money back from them? I know you said it's over a year now.
Mm-hmm.
How often are you getting reimbursement back from CMS, or are you not?
Yeah. So it's a little different for us. We are a contractor to state Medicaid pass through. And so through the APD process and then through our contract, it's monthly. We get monthly payment.
So from a fiscal perspective though, we actually have billing, we have account codes with Medicaid. And so they put that money in an account for us. And then they take our state match. Because again, Medicaid shouldn't have to pay the state match. It's the PD&P agency that pays the state match. So work with your Medicaid agency. Our fiscal folks got together, and I think they do like either quarterly disbursements of the funds or however they do it. But yeah, we work with them to make it so it's just sort of an accounting thing under Medicaid to do it. So it's fairly straightforward.
If I can just jump in real quick. The next slide I had, one thing I wanted to add, I know you saw this on a lot of the other ones. The one team that I don't think was included and mentioned is the budget team. I know when I worked at the state, budget team was huge. Not only do you have state funds that are usually on a fiscal year of July to June, but then you've got federal funds that are October to September, and that gets confusing, and even explaining that and making sure the budget team is on board with that. I can tell you from my experience with APDs is that the way they should request the funding is they should request, they should have in the request like 50-50, and then they should estimate the 75-25 in the APD. So based on when they anticipate this certification would go through, and then they would go in and request that. But as Cameron said, make sure you work with your budget team, make sure you have accounts set up, and ask them. Like I know in our state, they have to request a drawdown from CMS. It gets approved. CMS gives them the funds every quarter. They have to request a drawdown every quarter and keep track of that and make sure that that amount's available. It's a lot of work and it's a lot of budget numbers, but it is important when you want to make sure you have that money. Any other questions? No, quiet group. Okay, well, we have 8 minutes. I think I do have some slides. I had some slides that, I think, let me go over a real high level, and then I'm going to give you guys some time back. I know it's been 2 hours you've been sitting in here. A couple of things just to bring up. One of the things we found that has been a little bit time consuming is a data sharing agreement. One of the reasons that we need some of that is like some of the information to get Medicaid patient data that helps with cost allocation, since that's what CMS is looking for. It also helps with the running of the metrics and everything like that. We've worked with some states that it's taken forever to get just that piece of it. So that's something, even if you're envisioning you might not need funding for a year, something to consider that might be able to work on that ahead of time. As most of the PDMPs don't reside in Medicaid, you may need an MOA, an MOU, to be able to transfer the funds from one agency to another one. The budget accounts and the scheduling that we talked about. I think for the most part, we talked about the state match, we talked about the 75-25. Let's see, I think, one of the things that we found, and kind of level setting, I know we had discovered this, especially when you talk, I don't know how many of your PDMPs were involved with pulling data already for the annual DUR reports. I had to opportunity to work on a project with the state pharmacy directors. And one of the questions and things they said when working on that data is they had their way of saying things and the terminology, but it wasn't the same as the PDMT team. And they said even after like multiple meetings, did they realize that there was like a disconnect, the way they said something is not the way your team said something. So, continuing to have the meetings, I can't, reinforce that more, and working with the teams. So, I'm just going to keep that slide there. We kind of all decided that this was some of the things that we wanted to highlight, and some of the things, it's a team process, get the team involved. It seems overwhelming and inundating, but states have gone through it. You can do that too if it's something you're interested in. You've got good teams to work with. So I think I'm going to stop there. Jen, anything that you would like to add before we conclude?
I think just making sure that you get done what you need to early. So, I know it takes, the whole entire process can take from 6 months to a year. And it seems like that's so much time. In all reality, it comes and goes quick. If you count all the other things that you have to do, you count holidays, you count, new projects coming up, or hey, a clinical closure occurred and that's going to take 2 months. Getting what you can get done early, identifying those areas of metrics that you need assistance with, having those meetings. Like we have a meeting with Pam bi-weekly. We have a meeting with our vendor weekly. I wish I could say we have a meeting with Medicaid. We have a Medicaid agency on our bi-weekly meeting, but with CMS weekly, we do not. All of everything that you see in this presentation is just an amazing resource of information, and it helps you to really identify what you need to hone in on and what you need to identify early so that you can get that done prior to, so you're not scrambling to get it done last minute.
Great, thank you. Cameron, anything you want to add?
I know we talked about state project officers, so I was not allowed to contact our state project officer until about 6 months in. So it's sort of a trust building exercise with your Medicaid agency, because they rely so much on that state project officer for a lot of guidance. Unfortunately, our state project officer lives in Ohio, so he was right down the road from us. But so kind of it's a trust building exercise, particularly because they foster that relationship, and it matters so much to them. So, don't feel like if they're a little protective, understand that relationship is very crucial to their success and all the other things they have to do. So kind of be respectful of that as you move through this process.
Great, thank you. That's all that we have. Thank you very much for your time. Again, if you have any questions, let us know. Thank you.